Welcome to ATCM. Today we are going to discuss about a 15-year-old male who came to our complaints of a one-day history of vomiting, some mild breathlessness and decreased sensory. So we'll begin. A 51-year-old male was brought to ER with complaints of multiple episodes of vomiting since the previous day and night and with progressive decreased sensorium. And the next day morning he was brought to ER on an ambulance. So on arrival, he was drowsy and he was apparent to be breathing fast. I went to my primary survey. Airway appeared to be patent. There was no secretions, gurgling, or pouring of saliva, and he was kept up in a proper position. Breathing part, he was tachypneic with a respiratory rate of 32 per minute, and his fluid was 100% maintaining on room air. And on auscultation, he had a clear chest with bilateral equivalentry. Circulatory part, he had a pulse rate of about 100 to 110 beats per minute, and blood pressure was maintaining 130 by 70 millimeters of mercury, and CRT was less than 3 seconds. At this point, we secured 2 large IV cannulas of 18 gauge, and we continued our survey. Disability part, he had E4, V4, and M4 to 5 to 6. Basically, he was a bit confused, but individually he was obeying commands. Pupils are equally reactive. Exposure part, he was ephemeral and he has a GRB's record of 493 mg per deciliter, and patient clinically appeared dry. Basically, he had decreased skin turgor, he had dry mucosa, dry oral cavity and all that, so he appeared dry. So on reassessment after primary survey, his airway is still patent and maintaining. Breathing, he had a respiratory rate has slowly worsened to 36 per minute, and saturation is maintained 100% room air. Circulatory part, he had a heart rate of 108 per minute, and blood pressure is again maintaining around 130 systolic and 70 diastolic. Disabilities is slowly a bit more drowsy, like E4, V4, and M5. At this point, we took some more adjuncts, and the first one was an ABG. ABG was showing, the sample is what was an ABG. So it was showing a pH of 6.9. 6.9 was the pH, and PCO2 was 28.3, and PO2 was 30 because of EBG. The main thing is pH is 6.9 and bicarb is 6.3 with an annual gap of 19.1, and electrolytes everything was in the normal limits only, 4.5, and sodium was 128, and glucose was found to be high, 301, and also a slightly elevated creatinine of 1.4, and also lactate was found to be 2.2. So basically the ABG was showing a flying metabolic acidosis with a bicarb of 6.3. So it is actually again with a high anion gap, so it's a high anion gap metabolic acidosis with normal electrolytes. So we continue our survey. ECG was taken, we don't have the picture right now, so it was showing only sinus tachycardia with no acute XCG changes. And we also took a portable chest X-ray in ED. It was only showing normal lung parenchyma. There was no signs of any patches or any acute infection. And also at this point we checked the IVC also. It was almost completely collapsed, 1.4 centimeters and almost completely collapsed the IVC. So this point, considering the patient having severe metabolic acidosis with high sugars and low bicarb and all that, we are having a provisional diagnosis of DKA. So we started him on IV fluid, especially when after having a look at the IVC is collapsible, we started him on IV fluids. We started him on normal saline, 0.9 normal saline. 1 liter was planned to be given over the next 1 hour. And we continued our survey. So secondary survey. So basically this 51-year-old man, he's actually a non-diabetic patient taking both OHA and insulin. He had a history of low-grade fever since past 5 days. With also intermittently productive cough was also present. And since his symptoms worsened, he started taking reduced amount of food, and because of that, he also stopped taking his medications. Because he was having decreased appetite, he started reducing his oral intake, and also in order to avoid hypoglycemia, he completely stopped medications for the past 3 days. So since 3 days, actually, he was like in a generally at home only, in a tired state. He was slowly developing multiple episodes of vomiting and followed by decreased response since yesterday night. And since the symptoms worsened, the bystanders brought him to the hospital today morning. He doesn't have a non-allergic history, and the medications he is taking is metformin tablet 500 mg BD, then glimepiride 2 mg OD, and Huventstat 20 in the morning and 30 in the morning and 20 at night. And past medical and surgical history, he is a non-diabetic, diabetes since about more than 15 years by this time. And his last meal was about very minimal food, about 6 hours back. There was no significant even anything contributing to the current symptoms, except for the recent infection. So before finishing out this thing, we again reassess the patient. Now also he's maintaining his ABCs, but only thing is his tachypnea is persisting. At this point, we have started him on IV fluids, like fluid resuscitation has been started, and we continue examination. So it's a well-built and nourished meal with no other signs of pallor, ectocyanosis, club bleeding, lymphopathy, or edema. And system examination, CNS is now also drowsy. He is not obeying commands except for like only once in a while. But he's able to, like grossly, is able to move out for lunch and was no facial asymmetry noted. CVs was the normal limits, sorry, no murmurs or anything heard, as soon as 2 was heard. Respiratory, we could see obvious use of accessory muscles and also he was in distress. But he had symmetrical chest movements and auscultation, he had clear chest with equal air entry. GAT abdomen was soft, he did complain of an abdominal pain as such, and bowel sounds were. So clinical impression, considering the condition, basically the patient is having an HDA, metabolic acidosis with high sugars, and also increased anion gap. We are attributing to a diabetic ketoacidosis, and most probably it may be secondary or like it may be triggered by a recent chest infection. Considering his clinical symptoms, so an LRPA which precipitated DK. Along with that, he also had a history of drug default since past 3 days. So coming to the investigations, we sent all routine investigations like complete blood counts and then all renal liver and renal function tests and also all routine investigations. In that, we found that he was having slightly elevated inflammatory markers, the CRP of 120, and along with that, some elevated total count and also slightly deranged RFT. The lab creatinine was about 1.6, but he was maintaining adequate urine output and also serum ketones came to be 3 plus on initial for the first one. So this was the lab investigations and the reports with the normal limits only. So coming to the diagnosis of DK, basically it is mainly hyperglycemia, body depletion and acidosis. So with constant like criteria for diagnosis, it should be a blood glucose level more than 250 milligram per deciliter, then an anion gap more than 10 to 20. Usually it comes in about 20s or about 20, but usually anything above 10 to 20 is mandatory, and a bicarb less than 15 milliliters per liter. So if we have 3 or instead of bicarb we have a pH of less than 7.3 with moderate ketonuria, then we can constitute a diagnosis of DK. But usually we have to rule out other causes of like metabolic acidosis also along with that. So a blood glucose level more than 250 with an anion gap more than 12 and a bicarb less than 15 or a pH less than 7.3, we can attribute it to DK. Then management again it comes in three sets of management. One is first is we correct the fluid deficiency in the body. Then we go for recurrent abnormalities, and then finally we go for insulin. Always the first plan of management in DK is fluid resuscitation. On average, a person of an average adult loses about 100 ml per kg of fluid during DK, in which we have to replenish over a period of 24 hours. And this has to be this repletion has to be cautious in patients who are already having comas of cardiac or renal disease, because actually we have to deliver this fluid resuscitation on a much slower pace, and also in elderly patients and also people who are pregnant. So our plan of management will be initially we'll more aggressively correct the fluid by giving a 1 liter over 1 hour. Then we slowly reduce the rate 1 hour, next 2 hours, then over 4 hours, and over 6 hours. So our average plan will be to give about 6 liters of fluid replenishment over a period of 24 hours. And if the initial BP is low in this kind of patients on arrival, we can give supplementary fluids to correct their deficiency also. We can give boluses of 500 ml saline over a period of 20 minutes, always considering his previous cardiac status. And again, there's no response to this initial management, then we have to consider a secondary cause for this hypertension, like a septic shock or cardiac failure, which also need to be assessed parallel to the DK. And also, this kind of patients need to be admitted in at least in a high dependency unit or an ICU initially, so that we can provide continuous hemodynamic monitoring, and also, if required, we have to go for central line and also RT line for further management. So this is actually the overall flowchart of DK management. So basically, we complete our initial evaluation. In that, we send all routine blood investigations and everything, and we confirm the diagnosis of DK by the criteria we already discussed. Then our management comes under different headings like IV fluids, electrolytes, and insulin, and one optional one, that is bicon. The first one is, as we discussed, IV fluids, and depending on the patient's clinical status, we start our fluid resuscitation. The patient may be in severe hypovolemia, mild hypovolemia, or maybe secondary to cardiogenic shock, he may be in hypertension. Depending on the patient clinical status, we have to start our correction. So the correction we already discussed, we correct approximately 6 liters per 24 hours. That's our fluid status correction. And then the second thing is actually one of the main electrolyte in DK we have to look for is potassium. The main thing about potassium is actually, if you want to start insulin correction or insulin infusion, first we have to bring up the potassium to an adequate level. So if any time the patient's potassium is going below 3.3 milliequivalents per liter, we have to first correct the potassium to a particular range, then only we can restart the insulin infusion. So at any point it is below 3.3, we have to stop any insulin infusion if it's ongoing, or if it is not going, we should not start until the potassium is corrected. So our goal is to maintain the potassium above a range of 5.3 and then only start insulin infusion. So first start fluid correction, and if you're finding potassium to be low, start potassium correction first before starting insulin. So our goal is to maintain something above 5.3. And if the patient is having something between 3.3 to 5.3 milliequivalents, then we can start potassium correction along with insulin infusion. And if it is less than 3.3, we hold insulin infusion, give 20 to 40 milliequivalents potassium for correction, and bring it to a range of above around 5.3, and then we start insulin. And the third one, which we usually some people go for the first, but it has to be started after this too, is insulin infusion. Insulin actually, in case of acute DK, we go for IV induction, IV infusion. So the dose will be 0.1 units per kilogram as an IV bolus, which can be skipped in some certain cases, and we can then go for a continuous infusion of 0.1 units per kg per hour as continuous insulin infusion. And during the initial phase, this patient should be frequently reassessed, at least hourly or second hourly. We have to reassess the GRBS and, if possible, electrolytes every 4th or 6th hourly to make sure it's in the physiological range. So our aim is to bring down about 50 to 75 milligram per deciliter of glucose every hour. So we have to frequently reassess to see if it is achieving that goal. And at any point, if the serum glucose level reaches a level of 200, we have to add some extra dextrose infusion along with the our routine fluid resuscitation, so we can manage this, keep the glucose level above 200. So the idea is not just to bring down the sugar level, but we have to correct the acidemia and also to bring up the anion gap, or bring down the anion gap. So our aim is to narrow the anion gap, then improve the pH, and also at the same time bring down the sugar levels also. So initially we start with 0.1 units per kilogram per hour IV infusion. We monitor every hourly or second hourly, and once it touches 250 or 200, we add extra dextrose into the ongoing fluid, or we add a 10% saline and 10% dextrose infusion parallelly. So our idea is to maintain the serum glucose level between 150 to 200 milligram per deciliter, and same time we reduce the ongoing insulin infusion, but still maintain it until the patient recovers. And one option get this thing is actually controversial, and also it's not always preferred by all clinical clinicians basically. So if a patient is having an acute acidemia of less than 6.9 pH as his initial presentation, we can consider giving sodium bicarbonate. And if you're planning to give, we give 100 milliequivalents in 400 ml of dextrose, or maybe even saline we can give, preferably dextrose we give. And also, we also have to make sure at this point the patient is not having hypokalemia. The patient is having hypokalemia. Along with this infusion, we also add 20 milligrams of KCl also. So, sodium bicarbonate 100 milliequivalents plus 20 milliequivalents of KCl, we infuse over a period of 2 hours. Our only aim is to bring it at least above a range of pH of above 7. Once it touches 7, we stop infusion and then we continue our other plan of management. So, sodium bicarbonate actually, clinically multiple studies have been done, but the benefit is still questionable. But in some studies state that actually when the pH goes below 7, that is about 6.8, 6.9, it can affect the cardiac contractility and also the peripheral vasculature. So this has been found to be improved after giving sodium bicarbonate. So it's an optional thing. If you're giving, you can give over a period of 2 hours 100 milligrams. So again, going back to the management, IV fluids, electrolytes and insulin, mainly potassium. So when will you call it resolution of decay? The resolution of decay is not just about bringing down the sugars, but there is only one criteria of decay. That is, we maintain a glucose level between 150 to 200. The next one is actually we have to improve the bicarb level. It should come above 15 milliequivalents, and we have to increase the venous pH to more than 7.3, and also we have to normalize the annual gap between 10 to 12. So initially, when the patients presenting will be having about 15 to 20 annual gap, it will slowly start coming down once we start this infusion and fluid resuscitation. And also, in the initial phase, we have to monitor every day, hourly or 2 hourly, second hourly, the GR-base and other parameters of the patient, so that we can determine the insulin dosages. So this has to be make sure this is done in the initial stages. So again, key points in decay management. First is consider HD or ICU admission for this kind of patients because they require continuous hemodynamic monitoring. And if required, we can go for central line urinary catheter for urinary output monitoring. And also in case of severe acidosis, hypertension and all that, we can go for other parameters whichever is required as per the patient clinical needs. Then fluids. The most commonly preferred fluid is 0.9% or normal saline, which as we have discussed, actually we can give over a period of 24 hours. And once the sugar starts dropping below 250, we can start with IV 10% glucose and in conjugation with the ongoing fluids, or we can add some extra dextrose to the ongoing saline infusion. And then initially we start with, as we discussed, insulin infusion and also if required insulin bolus also, both with a dosage of 0.1 units per kilogram. And then once the patient starts improving or once the decay resolves, we change this to a subcutaneous basal and bolus dosage. That we can do after that we stop the infusion, we take the entire dosage requirement of a 24-hour period and then we change it to subcutaneous dosage. So that is fixed high dose insulin that we start after resolution. And the third one is potassium replacement. As we already discussed, always start or give correction of potassium first before starting insulin infusion. So our target will be to maintain it above 5.3. And then again ongoing ICU monitoring, we have to always continuously monitor the blood glucose level, ketones level. We have to repeat the ketones intermittently to see if the leakage is resolving. Then continuous urine output monitoring, and also intermittently we can do the venous blood gas to see if the pH is also improving. And also in some cases, the thing is also most important screening factor for decay is infections. So in case we are getting raised inflammatory markers as in this patient, if you're getting those kind of pictures in the initial stage of admission, we can consider giving broad spectrum antibiotics depending on the patient's symptoms. And also if the patient is actually because the clinical situation is immobilized for a long time, we can consider starting him on thromboprophylactis also. We can start him on heparin as DVD prophylaxis. And also suppose the patient is unable to take feeds or anything, initially we might have to put him on NG2 for adequate feeding and all that. And apart from this, all routine ICU care will be recurring for this kind of patients at least in the initial stages of treatment, and then slowly we can taper him off to a regular patient and we shift out to ward or something later on. This is the basic overview of decay management. Always a critical care management in the initial stages, fluid resuscitation, then electrolyte management, then IV insulin infusions, then related to subQ, then continuous hemodynamic monitoring and lab monitoring, and then a broad spectrum antibiotics if required for prophylaxis, and also all the supporting care. So finally, what happened to this patient? Initially, the pH was 6.9 with a bicarb was 6.3. We had started a management with IV fluids, then we gave potassium correction, along with then we started insulin infusion. It started slowly improving 7.1 with a bicarb of 11.1. And iron gap from 19 it has come down to 15. And then finally, the latest VVG showing 7.34 pH with bicarb of 14.5, and the iron gap has come down to 8.2. So it's almost in the resolved state with a glucose of 135, lactate everything coming to normal. So this is the final stage which we got today morning. So the VVG showing some slight hypokalemia which we already started correction, but otherwise he's hemodynamically much improved compared to the initial first patient. Thank you.